Welcome everyone to the Special Populations Corps 2024 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you so much for joining us for today's presentation. We're very excited to have Dr. Corrie McDaniel of the University of Washington School of Medicine and Seattle Children's Hospital with us to discuss changes in access to care for children hospitalized in non-children's hospitals. Before we jump in, if you have any questions during the presentation, please feel free to unmute and ask. We'll also have some time at the end for Q&A as well. To get us started, I'm going to turn it over to Jim Lloyd, who's a research specialist here at the Center for Health Services Research at Rutgers, to introduce Dr. McDaniel. So Jim, over to you.
Thanks, Kylie. Dr. Corrie McDaniel is an associate professor of pediatrics with the University of Washington School of Medicine and a pediatric hospitalist with Seattle Children's Hospital. She completed her medical school training at Midwestern University, followed by a pediatrics residency in chief year with Advocate Children's Hospital in Chicago, Illinois. She's a funded investigator with the Agency for Healthcare Research and Quality, assessing strategies to address inpatient disparities for children in rural communities and non-children's hospitals. She's also an advisory board member with the American Academy of Pediatrics Pediatric Acute and Critical Care Quality Network and assistant editor for the journal Hospital Pediatrics. We're excited to hear from Dr. McDaniel.
Great. Let me share my screen. Okay. Everyone can see this okay?
Yep.
All right. Well, thank you so much for inviting me today. I am honored and excited to talk about access to care for children in rural areas. I have shortened my title a little bit since I submitted it originally to Kylie, since the first one I proposed was essentially the length of an entire manuscript. I am more than happy as we go through to take questions. So feel free to go ahead and unmute and ask while I'm going through things. Otherwise, we'll have time at the end to chat. So I'm going to be talking about the changing landscape of hospitalizations for rural children and the impact to their communities. I have no disclosures, although my time is funded by AHRQ. So I'm going to kind of talk about things in three sections as we go through today. First, the changing landscape to access to hospital-based pediatric care, then impact upon rural communities, and then lastly, innovations and future progress. Where can we go from here? So over the last 20 years, almost 200 rural hospitals have stopped providing any inpatient care. These hospitals, as you can see in this image here, are kind of scattered throughout the US, but do center more in the South and the East. For adult patients, the loss of access to acute care has increased morbidity and mortality for rural residing patients with a variety of health conditions. The literature includes everything from cerebral vascular accidents to risk in pregnancies. These graphs here are a difference in difference analysis of patient-level mortality before and after hospital closures. And what they show is that there's really no general impact of closures on mortality, but when looking at the impact of rural hospital closures on patients, there's an increase of mortality by almost 9%. And when stratified by both Medicaid and racial minorities, rural hospital closures lead to an increased mortality by 11.3% and 12.6% respectively. We also note that hospital closures have a subsequent spillover impact on surrounding hospitals that remain open. What we can see here in this graph now in the top right is an analysis done by Lee Song that is looking at the impact of hospitals that take on patients after a hospital has closed. And what we see is that while operational efficiency and bed utilization goes up, survival duration for patients goes down, and 30-day all-cause mortality goes up. And so these trends are not insignificant. When we take the impact of what has been happening within the adult care world and then look at it through a pediatric lens. So current data show that in the US, 1 in 5 hospitals have closed or lost their pediatric units since 2008. This map here on the left is showing the number of beds per million children in 2018. And you can see that there's significant variation with particularly low bed counts in the West. Now, what this averages around to is around 370 licensed beds per 1 million children in this country. To put that in some level of perspective, there are approximately 270 beds for every 10,000 adults. That's a ratio of approximately 1.5 peds beds for every 1,000 adult beds. In addition, when we look at how things have changed, we see that the changes over time are not equal. While the West is lower overall, the change is also more variable, with states like Montana adding beds, Arizona losing beds, and Nevada, who is one of the lowest states, losing even more beds. The East Coast is a little bit more complicated. It's more highly populated, it's more densely populated, and changes in bed counts can vary dramatically within really small geographic locations that we don't see as prominently in the West. Now, pediatric closures are also not happening evenly across types of hospitals that care for children. So, to understand the nuance of this, we have to diverge for a second into understanding some of the terms that are used to define where children receive care. First, when thinking about where kids get care, kind of logically, things break out into children's hospitals and non-children's hospitals, or general hospitals. This seems logical, but like most things within healthcare, insufficient. So then we break down where care is happening into freestanding children's hospitals and non-freestanding children's hospitals. But non-freestanding children's hospitals are complicated because they are also part of general hospitals. In addition to that, they have many names when trying to identify what to call a non-freestanding children's hospital. They're also called children's hospitals within general hospitals, operationally dependent children's hospitals, and then beyond that, we have general hospitals that admit children onto designated pediatric units, and we have general hospitals that admit pediatric patients to adult or pediatric beds, but not a specific unit. Now, when we look at these designations, we know that there are 52 freestanding children's hospitals in the United States. That is the only designation that we actually know is accurate because you can physically count the buildings that are freestanding. The rest of the designations do not have any strict definition for how we define any of the remaining hospitals. We know that there are somewhere between 200 and 250 non-freestanding children's hospitals in the US, but definitions for this vary greatly. For example, All Children's associated with Johns Hopkins is a non-freestanding children's hospital. It is physically attached to Johns Hopkins, which is a general hospital. And so it is considered a non-freestanding children's hospital. However, it's obviously a very high functioning children's hospital. It has more than 300 beds. They do multiple different kinds of transplants, a wide variety of access to pediatric subspecialties. Similarly, also called a non-freestanding children's hospital, but just down the road from me in Tacoma, Washington, there's Mary Bridge Hospital, and it's attached to Tacoma General. It's a children's hospital, non-freestanding, but has 80 beds, has less than 10 pediatric ICU beds, and does no transplants. So the variety that gets lumped together into this one categorization is pretty broad. We know within the data that there are around 1,400 hospitals in the US currently that have designated inpatient pediatric units. And this number sometimes includes non-freestanding children's hospitals and sometimes doesn't. And then there's another 2,500 hospitals that admit pediatric patients without a PEDS unit. This landscape is important then as we look at trends for consolidation of care. So how did we get to this 1 in 5 hospitals closing their PEDS unit? So this initial analysis that I'm showing here on the left is one that we published this fall using the Healthcare Utilization Project's KID inpatient database. The KID is a nationally representative sample of pediatric inpatient admissions gathered from 49 states, everywhere except Alabama. we stratified hospitalizations into 3 categories purely for simplification purposes. So freestanding children's hospitals, that's your top line, non-freestanding children's hospitals, that's your middle line, and non-children's hospitals, that's your bottom line. What you can see is that in the last 2.5 decades, pediatric inpatient admissions has decreased in non-children's hospitals dramatically by around 55%, and increased dramatically in freestanding children's hospitals. Furthermore, when we look at an analysis done by Joanna Lionar and colleagues, what we see when we exclude non-birth hospitalizations over time is that when you look at urban-rural characteristics of hospitals, we see the most substantial decreases at rural hospitals. They demonstrated a 4-fold decrease in urban non-teaching hospitals for the provision of pediatric services. So in the context of what is the spillover effect seen within adult medicines within closures, one may presume then that the closure occurring in urban areas may not have the same impact upon child health as those in rural areas. And that really led us to ask kind of 2 main questions to better understand these trends and their impact on rural children specifically. So number 1, where are children being hospitalized? And how is this changing over time? And then number 2, for common pediatric conditions that require hospitalization, how far are rural residing children needing to travel to receive care? So we conducted a longitudinal study of pediatric hospitalizations using, again, the HCAP databases, but for this one, we used the SID, or the state inpatient databases. Unlike the KID, which I showed the analysis from earlier that represents a sampling of hospitalization, the state inpatient databases includes inpatient discharge records encompassing all patients regardless of payer within a given state and is released in 3-year intervals. We included 8 states: Colorado, Florida, Kentucky, North Carolina, New Jersey, New York, Oregon, and Washington. We chose these states as we had longitudinal data for them over our entire study period, and because we were able, within the data provided within the SID, to tie it to the American Hospital Association identification numbers so that we could get zip codes for the hospitals in order to identify them. So then within each state, we stratified on the patient level by rurality. So breaking into rural and non-rural, and then further categorizing using RUCA codes, or the rural urban commuting area codes. Specifically, we used large rural or micropolitan, which you can see in kind of that medium shade of green, which we defined as population of 10 to 50,000 people, small rural within a population of 2,500 to 10,000 people, and then isolated rural, which is less than 2,500 people. And you can see these different categories in shades of green on this map. And so we included micropolitan within this subset, which is, some will argue sometimes that these are considered rural, sometimes not rural. These are communities that have historically supported small community hospitals, meaning they have operational budgets of less than $35 million a year. And furthermore, most of these hospitals have more than 25 beds, which means they don't qualify for federal critical access designation and then are at increased risk for hospital closure. So then using these data, we addressed kind of those 2 main aims. First, looking at hospitalizations overall, and then by common diagnoses. And so overall, we looked at location of hospitalization, agreement between residents and location of hospitalization on the patient level, and then rates of interfacility transfer. And then for the common diagnoses, we looked at changes in distance traveled over time. We used median regression with the year as our independent variable to assess changes in distance traveled. And we used distance calculated in linear miles between the centroid of the zip code of the patient's residence and the admitting hospital. Obviously, that's going to have limitations since we don't know where within a zip code a child is residing, but it was the best way that we could be accurate in repeating through all of the tests. For our trend test, we use the Cochrane-Armitage trend test for concordance or agreement between a child's residence and their location of hospitalization. And then we calculated odds ratios for concordance by diagnosis when we get there. So first, what we found was that inpatient hospitalizations for rural children decreased in just raw numbers by more than 50% from 2002 to 2017. This is likely multifactorial. Over that time period, we saw innovations when it comes to things like pediatric vaccines with rotavirus and pneumococcal that we both know decreased numbers of hospitalizations. In addition, the Medicare two-night hospitalization rule to qualify for inpatient status changed in 2014, which dramatically impacted peds, where the average length of stay is 2 nights with an interquartile range of 1 to 3. So at least some percentage of inpatient stays then became observation stays and aren't captured in these data, but is following at least concordance with what we have seen in other publications with decreasing percentages of hospitalizations for children. Then, very much in line with the data I presented earlier, we similarly saw a substantial shift away from children being hospitalized in general hospitals towards children's hospitals, with decreasing from more than 3/4 of children in 2002 to just over 1/3 in 2017. So then we assessed for location of where rural residing children were being hospitalized. So previously that was types of hospitals. So now we're thinking about location of hospital. And what we see is that the proportion of hospitalizations in metropolitan areas for rural residing children increased from just over 30% in 2002. These are the green circles on this graph, to almost 75% in 2017. Proportionately, and obviously, hospitalizations across all other rural stratifications decreased over time. Following the trend of hospitalizations in metropolitan areas, children requiring interfacility transfers for hospitalizations, so these are the orange triangles or diamonds that you can see kind of along the bottom, for interfacility transfers, meaning that a child presented first to one hospital for care, but subsequently had to be transferred to another hospital for either ongoing care or hospitalization, increased from 6% in 2002 to 26% in 2017. This means that more than 1/4 of rural residing children who presented to care at one hospital required transfer by ambulance or air for additional care. We took this one step further then and looked at agreement in rurality. And this means that if you are a child from a small rural area, you were then able to be hospitalized in a hospital in a small rural area. And these data mimic the same pattern that we saw for definitive hospital location. In 2002, if you were a child from a rural area, more than half of the time you were likely to be hospitalized in a local hospital with your same level of rurality. These are, again, the green, which is somewhat overlapping, you can see with the small rural blue triangles. In 2017, this was occurring 20% of the time. By 15 years later. So a decrease from 1 in 2 children to 1 in 5 children over that time period. Next, we looked at the 10 top most common conditions for hospitalizations within pediatrics. And we looked at changes in distance traveled over the same time period, so from 2002 to 2017. And first, what we see is that the average distance traveled for common causes of hospitalization increased by more than 3 times the distance. Next, for conditions such as epilepsy and diabetes, diabetes with complications are things like DKA, which is the most common reason for a child with diabetes to be hospitalized. Rural residing children in 2017 were traveling 40 to 50 miles for hospitalization. And then for common run-of-the-mill, kind of our bread and butter inpatient pediatric diagnoses, rural children were on average traveling 20 to 30 miles. Now, this increase in and of itself is somewhat dramatic, but even more so when we consider the management of these conditions. So within pediatrics, the primary interventions for acute gastroenteritis, for fluid and electrolyte disorders, is IV fluids and supportive care. We usually don't treat with antibiotics. We don't need to put in advanced lines. We don't need advanced imaging. You don't need subspecialist care to help care for these children. And yet rural residing children are having to travel increasing distances for hospitalizations for very basic inpatient needs. Not unexpectedly then, when we compared the odds of hospitalization in a hospital local to a rural child in 2002 to 2017, for all conditions, excluding chemotherapy, the odds of a child being hospitalized in a rural hospital was a quarter of 2017 compared to 2002. And that makes sense kind of based on all the other data that I just presented. So what do these 15-year trends tell us? Well, they tell us, number one, that inpatient hospitalizations have decreased by half for rural children, that 3 of 4 rural residing children are hospitalized in metropolitan hospitals in 2017. And that when we compare 2017 to 2002, we see that rural residing children required increased interfacility transfers 4 times more commonly in 2017 than they did in 2002. They had to travel 3 times greater distance for hospitalization for very common basic conditions. And they were 4 times less likely to be hospitalized in a hospital within their same rural area. So obviously the analysis has multiple limitations, including that the analysis is based on a subset of states. So while the represented states are kind of geographically diverse, if you remember back to the initial map that I presented, it doesn't necessarily mean that they are generalizable to the entirety of the US. This may be particularly true in very large states such as Alaska, which is both highly rural and expansive geographically, and to very small states like Rhode Island, which is densely populated and seeking care across state lines may be more common. We also can't account, speaking of seeking care across state lines, for care that was received out of state for patients. So patients living on or near a state border may cross to another state, and that would not be captured within this analysis. And then we do not account for changes in rurality over that 15-year period, which probably also plays into concordance of care. So why does any of this matter? Well, it matters because as local hospitals provide less pediatric care, it leads to a cascade of effects on a systems level. So when hospitals provide less care, clinicians obviously become less comfortable caring for children. When a child then presents to the emergency room or to the hospital, it's not just the physicians, but it's the nursing staff, the respiratory therapists, the pharmacists. Everyone is less comfortable caring for that child. In addition, you're using less of your supplies. So you have a set of supplies that is not getting used. It's not being reordered. They expire. Then you have to throw them away. Now you stop stocking PED-specific supplies because you're just not seeing as many children. This leads then to when you have children presenting that need care to overdiagnosis and over workup for common conditions and under recognition for less common conditions. And then you have inadequate supplies and you're less prepared for when a child presents with a true emergency. We then see that all of these things lead to increased interfacility transfers, and parents are smart. They recognize that their local hospital is not providing care for children. And so that leads to parents voluntarily then bypassing local hospitals to go to other hospitals, which further decreases the comfort that a given hospital has with children. All of these then lead to overburdening and overcrowding of EDs that do provide pediatric care. And we know that 70% of interfacility transfers, so kids that are sent from one hospital to another hospital for additional care, are discharged within 1 day with no advanced care provided. So in moving then from that systems level of child and family to the actual impact on that child, we know that the impact of hospitalization increases the farther from home a child is hospitalized. So these include things like delayed diagnoses, costs, stress, school absenteeism, and community level disaster planning. And I want to walk through each of these fairly quickly. So first are delayed diagnoses and inappropriate medical treatments. So this is just a sampling of what we have out there in the literature right now of multiple examples of children from rural areas having delayed diagnoses or over medicalization because of less familiarity with taking care of children. Obviously, things like delayed diagnosis of a CNS tumor is a fairly big deal. However, that's less common, but higher rates of unnecessary CT scans for abdominal pain, headaches, excuse me, febrile seizures, or chest x-rays for bronchiolitis. Bronchiolitis is the #1 reason that children get hospitalized in the US outside of the newborn period. And unnecessary radiation exposure is not without potential harm. And so we see that not having hospitals locally that are prepared and comfortable and ready to take care of children has impact on actual medical outcomes for these children. Next, we have costs. So this is not just cost of hospitalizations, but things like days off work, caring for a child in the hospital, when you have to drive long distances to care for your child, coordination of care and requests from help for others, for other children or adult dependents in the home. You have travel costs, whether that's driving, parking. If you have to come, like here on the West Coast, if you have to go over the mountain pass and it's winter time. And last night, for example, our mountain pass was closed. So if your child got flown from the other side of the mountain pass over to Seattle for hospitalization, you could not come across the pass in your own vehicle. You either had to drive all the way around through Oregon, or you had to wait till the pass opened again today. Accommodations, meals, all of these things add up. And in a study out of Australia, excuse me, that adjusted for US dollars, approximated that the average out-of-pocket expense for a child hospitalized, not including the medical bills, is $450 a day. That adds up very quickly when now you're commuting even longer distances. Next, obviously money being part of it, but hospitalization in and of itself is stressful. These are amplified when children are hospitalized far from home. I'm going to show 2 quotes from a qualitative study that was conducted with rural parents of hospitalized children. And you'll see that distance plays a distinct role. Hospitalization is obviously stressful for everyone, but hospitalization where a caregiver cannot physically go home because their child is hospitalized is an even bigger stressor. So this first one, my son will have a long recovery from his accident, and we live 185 miles away from the hospital. I called my boss and told her I won't be back to work. I'm a single mother with twin boys, but I'm not leaving the hospital. And then this one is kind of in that same vein. I work at a grocery store. I get paid only when I'm there, but my son is sick. I can't leave him. We live too far. I don't know what we're going to do. Next is school absenteeism. And this is kind of an interesting concept to think about because for the most part, our length of stay in pediatrics is very short. But the average child, after being discharged from an inpatient intensive care unit, misses on average an additional 9 days of school. However, we know that almost 3/4 of children who are transferred are discharged home within 1 additional day. Now, these are cases where the majority, if seen at a hospital with pediatric care, may have been able to actually just to be discharged home from the emergency room, not requiring an interfacility transfer. So when a child arrives to a receiving hospital after an interfacility transfer, the hospital itself has increased odds of admitting the patient regardless of the necessity for admission, simply because the child was transferred for further care. So for that example that I gave with the mountain pass being closed just a minute ago, if you were flown over our mountain pass, let's say, and hospitalized here last night, even if you were evaluated in the ED and it was determined that actually you've been off oxygen now on the flight over here, you could go home. Well, now we actually are not discharging you because your parent isn't here. We can't send you back over the pass because the pass is closed. So now we have to bring you into the hospital. And those things add up for missed days of school, missed days of work for parents, and ultimately, when you have kids that have chronic conditions that need multiple or repeated hospitalizations, whether those are your kids with diabetes or with epilepsy, like we showed earlier, that contributes to lots of missed days of school that might be necessary and a lot of missed days of school that potentially are avoidable. And then lastly, local access, lack of local access has implications in community level disaster planning, surge capacity, and public health activities. We've seen two excellent examples of that, of how rurality and strain on access impacts public health in recent years. So we had the pandemic, obviously, and then the triple-demic in the fall of 2002 with RSV, flu, and COVID all surging at the same time. And both of these caused intense stress to the rural healthcare system with backlash upon referral centers and poorer outcomes for rural residents. And just to kind of dive into this for a split second. This is an analysis looking at the state of Florida during 2020, or the first year of the pandemic, for pediatric ED visits and hospitalizations. And ultimately what they saw was a $1.37 billion decline in charges for pediatric care in 2020. Now, hospitals most impacted by these declines were hospitals already in underserved areas where finances are already strained, increasing the risk of further closures upon a strained healthcare system in medically underserved areas. So there's always a snowball effect when you are an at-risk hospital for closure. So solutions, right? Be great if there were some magical solutions. I have no magic, but I have a few things to throw out there. Obviously, solutions to sustain pediatric capacity are needed on many levels. First, and this is not exactly a solution for access, but we need improved ways within data to classify like hospitals. The kind of differentiating that I talked about earlier between children's hospitals and non-children's hospitals and general hospitals and all of those classifications, the issues with definitions for identifying hospitals is not only within pediatrics. It's seen in analyses attempting to examine policies for safety net hospitals, for disproportionate share hospitals, depending on what definition you use. And so then layering on the PEDS component becomes even more challenging. We are working on approaching this within PEDS using a K-cluster technique to group like hospitals or peer hospitals that provide PEDS care by severity and diversity of conditions treated. As hopefully this may allow for some better grouping of hospitals for improved targeted interventions, better resources and policies directed to hospitals that are more similar. This becomes particularly critical for rural hospitals, where policies that are enacted based on inaccurately generated data can further worsen disparities rather than address them for rural children. Next, I know this is a big topic, Medicaid reform. Most rural children have healthcare insurance through Medicaid, and healthcare policy incentivizing hospitals to provide inpatient pediatric services through increased Medicaid reimbursement may help to support financial sustainability for the provision of PEDS care. And although we can talk a lot about all the other potential solutions, in the end, healthcare in the US remains a financial institution. And the only mechanism for ultimately assuring access and sustaining care for children in rural hospitals is to make it financially viable to do so. And so to have true policy impact, we are lacking a lot of necessary data still. We need to understand the policy impact of current reimbursement structures upon pediatric care in rural hospitals. We need better defined health outcomes for rural children, especially for common conditions, that like middle bracket of conditions that I showed earlier with bronchiolitis and gastroenteritis and pneumonia, for children with medical complexity, and for mental health conditions. In addition, we need to understand what the spillover effects are for other hospitals when units close. We see that there's a spillover effect when hospitals close for adults, but what is that impact for children when units close? Next, we need innovative solutions to maintain comfort and competency in the provision of pediatric care for clinicians. Again, this is not just physicians, this is nurses, this is respiratory therapists, this is kind of that whole team that goes into caring for patients. There are programs intentionally designed to support rural communities. These are things like the Rural Physician Peer Review Program. This is an example out of Texas, which is obviously a very large, mostly rural state that has created a network of rural hospitals that train together using simulation and feedback around obstetric emergencies, and has demonstrated outcomes of decreased clinician professional isolation and improved retention. Furthermore, we know from our colleagues in emergency medicine that improving pediatric readiness in the ED, particularly in rural EDs, decreases unnecessary transfers and improves outcomes. And we need a similar type of thing within inpatient readiness. This work by Dana Quinibi used a modified Delphi technique. I know that table is kind of small, but it just took the domains of the ED PEDS readiness and tried to apply it to the inpatient realm as a starting place. But that's all it is at this point, is a starting place for where we could go to maybe better prepare hospitals to care for children. And then lastly, because no discussion on potential solutions would be complete without talking about technology, this is an area that is evolving in a really rapid and potentially exciting way. Obviously, telehealth is part of this, as it's the first idea everybody cites. We saw huge changes that took about a decade's worth of leading up to it, of change that then happened over a year during COVID, in improving telehealth access. But it's just the start. So innovations such as Project Echo, which is projects based on a spoken hub and spoke, there we go, wheel kind of set up for extension for community healthcare outcomes of connecting hospitals to a larger hub using telehealth interventions. And then Paradigm, which is a series of programs that is looking to really think innovatively about how do we share technologies, how do we share imaging modalities, things like this, to improve access to services within rural communities. So pediatric care in the US is consolidating. Whether we want it to or not, it's happening. We know that the impact upon rural children has led to significant increase in distances traveled for hospitalization, with resulting burdens upon families. And we have some of the pieces for solutions, but there's a lot more work to be done. And that is the end of my talk. Thank you. I want to specifically call out some of my incredible mentors and people that I have worked with. Joanna Lionar is out of Dartmouth. She's a health services researcher and really my inspiration and mentor for all things. Larry Kessler is a PsyD at the University of Washington. And then Matt Hall and Jay Barry. Matt Hall is at the Children's Hospital Association and Jay Barry at Boston Children's. And that is the end of my presentation. If there's any questions.
I have questions to start us off, but if other people have questions, they should go first.
It's all
okay.
you.
I'll start. The examples that you gave, which are sort of examples that come up an awful lot in disparities research, Florida, Texas, can you separate this, can this challenge with children's hospitals really be separated from the failure of some states to expand Medicaid, or is at least is that an additional barrier for children in those states, some quite large, that don't have access to expanded Medicaid? And what does the lack of expanded Medicaid tend to do to that system that you're talking about that needs to be prepared, needs to be resourced? and so on?
Yeah, that is a really important question fundamentally, because I strongly believe that healthcare is 90% of all decisions are based on financial motivations. And so we do not have any policy, like national policy analyses that have looked at Medicaid expansion and its impact upon inpatient provision of care. I do think that, one of the things that I am currently working on that I didn't present because I don't have any data on it yet is the idea of whether or not critical access hospitals, which a large subset of those rural hospitals are going to fall into. There's about 1,300 nationally spread across 42 states, of which over the last, 12 years, as states have expanded or not, Medicaid includes the adoption of cost-based reimbursement for critical access hospitals for Medicaid patients, not just Medicare patients, and whether or not that has impacted those hospitals to maintain pediatric services. And I don't know the answer to your question, but I do think it's a really important question when we start to think about how do we influence policy that may ultimately be impactful in sustaining access.
Right, that's great. I mean, I sort of, it's always this fine balance, because in our work we want to help improve things rather than hopefully not increase polarization if we think that polarization is just going to make things worse. But sometimes you kind of have to speak truth to power, and you have to say, this is what is being seen. And when you look at it from a mapping point of view, which increasingly we like to do,
it's not hard.
Yeah, that's something that people can really relate to, and they see pretty clearly what the imposition of, yes, it's financial, but many of us sort of view it for the last, ever since Obama, as being as much ideological, that it doesn't actually make financial sense for the southern states, but it would be a win for the Democrats if they allowed it to happen. So anyway, those are some, but somehow I see that this is yet another spillover that I certainly haven't seen a lot on of those same kind of policies. If you have and the failure to expand Medicaid is one barrier. Another is the very aggressive unwinding that so many states are doing, which will also have some of those similar effects. So, if you've got poor kids with expensive healthcare needs and you're not willing to maintain that safety net, some of the concepts seem kind of predictable. I don't know, Jim, did you want to add to that?
Well, I don't know about adding, but just another question I had was about when these kids get, transferred into the other hospitals. Is there a situation where they're displacing kids in those hospitals? Like, does it change the mix of diagnoses for which kids are getting admitted in those hospitals? Like, I would imagine you'd see kids in rural areas getting brought into certain hospitals, but like rich suburban kids, maintaining access. And if anyone's going to lose access, I assume it's going to be poorer children in those areas. But I was wondering if you had looked at what happened to the hospitals that were like sort of receiving those kids then, if anything had changed.
Yeah, we saw, the system be very taxed from a pediatric standpoint in that fall of 2022 triple-demic, where children's hospitals were totally crushed and overwhelmed by just their local population of children that needed care. Because all of a sudden, we went from 2 years of no children being sick, like the data from Florida that I presented, to now everybody got sick at once and got really sick. And so urban areas, or all but one children's hospital is in an urban area. And so all the kids in those urban areas were just as sick as the rural kids. So they all took up the beds. And what we saw then is that rural hospitals that are not used to managing children were forced to keep kids and manage them either over the phone with the ICU doc. Children were having to be transferred states away. That's a big deal pretty much anywhere. We had to send kids down to California. On the East Coast especially, this was a big deal because multiple states away, you're very densely populated, but you tend to also have a lot of hospitals. And there just was no capacity. And so it really
this is not for procedures or evaluations that should be done in only a few centers of excellence. This is for more routine things.
For everything. There were no beds.
Yeah.
It was kind of like in the crush of the COVID peak when there were no adult ICU beds anywhere. It was a similar type of thing, just on a much smaller scale for children, of what happened in the triple-demic. So there is the spillover effect. I don't know that we have any actual data that shows that, though, other than everybody's anecdotal experience from 18 months ago.
No, thanks. That's really interesting.
Be an interesting thing to look at, Jim, for one of many things that you'd be looking at from the New Jersey perspective. One thing that we've noticed, I don't understand exactly what the relationship is, but we have sort of major hospitals that all of a sudden are sprouting up a children's hospital associated with the general hospital. And you really wonder whether it is a full-scale children's hospital with the same capacities as freestanding children's hospitals, or whether it's marketing.
And there is no definition for a children's hospital. A children's hospital a lot of times it's motivated by exactly what you said, marketing, and kind of like how you put yourself out there to the world. Within the Children's Hospital Association, which like verifies children's hospitals, even they state that there's like the bar to be considered a children's hospital is extremely low, which leads to vast variability in what is considered a children's hospital.
Well, one of the many practices, because we always struggle, and it's not easy in trying to define, sometimes with mixed methods research, what are the characteristics that would truly make a particular setting what it claims to be. And when you think about some of the things that children's hospitals historically had a lot of sort of public benefit from, one of the things was that they belonged to these associations where kids with specific conditions, let's say cystic fibrosis, could be data could be shared in a common format. The hospitals could be benchmarked, and that kids could be on, could be on trials. So if in cancer, most kids are on trials, presumably that is largely through the children's hospitals, although you probably know, to what extent it's through the cancer centers. But this is, in other words, like, how do we define, for purposes of giving special financial resources to the hospitals that we want to, that there's a public benefit building up their capacity. This is where the kind of wonky things that you're talking about become so important.
That's where those like nuance in how you define populations, define like hospitals, becomes really important, because policies implemented based on definitions,
Right.
if your definitions aren't accurately or appropriately grouping things, can have cascading effects, some of which you may want, most of which you probably don't want.
Right. Is there how much of a presence of for-profit is there?
I don't know the answer to that off the top of my head. Within children's hospitals, very little. Beyond that, within general hospitals, I actually don't know what the percentage.
Oh, general hospitals is a huge deal, and there's a lot of literature suggesting various quality issues that come up when hospitals go for profit. I'm glad to hear that at least the children's sector has mostly stayed with nonprofit, because our systems of regulation are not just not good enough for the public sector not to get completely ripped off by sophisticated private equity people and lots of other people who decide that the only criterion is maximizing their profit.
There's a very limited number of things that make money within pediatrics, surgical NICU, and like advanced pediatric surgery. And that's it. Advanced being like CV surgery, neurosurgery, ortho, ped specific ortho. Aside from that, even children's hospitals like don't make money. And so everyone relies on foundations and donations. So the motivation to be a for-profit hospital in order to receive vast amounts of gifting is a little bit different in the peds world.
Yeah. Wow, this is so fascinating. The other people have questions. Joanna, it was great that you were able to join and hear your the fruits of your mentoring work. Anybody else? Elizabeth, before we close?
No, I enjoyed listening, but yeah, I just don't know very much about children's hospitals at all. So this is, yeah, a great kind of intro to this space.
Well, I guess one last question, which Elizabeth is particularly interested in, which is the role of children's hospitals for kids with severe disabilities, where they are not even able to get outpatient or ambulatory care in a very receptive manner, because they're challenging for to what extent do they end up going to outpatient clinics of children's hospitals, or what role do the children's hospitals have to play for this substantial population of people, for example, with intellectual and developmental disabilities?
Joanna actually just last month published a paper on looking at children with medical complexity and hospitalizations for rural children. And for the most part, rural children with medical complexity wind up at children's hospitals, which are all urban.
Yeah, that's what I would guess.
Which is actually problematic because a lot of times when they are in extremis, so if you are a trach vent kid that lives at home, you've got a VP shunt, something happens with your trach and you show up at your local ED is terrified of you. They're terrified of you. And that in and of itself can lead to bad outcomes. So it is problematic. And then when you have non-acute things, parents learn that they can't trust their local EDs. So they bypass them, which again, like that cascade that I showed, further underscores the fact that then the hospitals are afraid of them, because then they only show up when they're in extremis, as opposed to the other times where maybe they could actually manage some wheezing or things like that.
What a great point. And there was a time, I think things have evolved a bit, when you would talk to families of DD people in the state, and they would say, there's only one place to go. You have to go to Morristown. Well, if you're living in Cape May, that's pretty hard to have to go to Morristown for routine care.
Long ways.
Yeah. All right.
I say we are coming to the end of our time.
Yeah. So
But just
thank
wanted to
you.
first thank
Yeah.
you all.
Thank you so much, Kylie.
Oh, thank you. No, and of
Thank
course,
you.
thank you,
Thank you,
Corrie,
Corrie.
for a wonderful presentation and for everyone for joining. We're really grateful for your time, Corrie, and sharing this wonderful talk with the NJAX community. So thanks everyone again. Take care, and we'll see you at the next seminar.
Thank you for having me.